A very good afternoon and welcome back to this lecture series on laparoscopy and minimal access surgery. So today's lecture is ergonomics in laparoscopic surgery. Ergonomics in laparoscopic surgery, friends, it is exactly as important as knowing your car before you drive it. That is what ergonomics is all about. Before I talk about today's topic, I find it important to tell you that the first step in applying scientific method consists in being curious about the world. And I should also say that if you work with the hands, you are just a laborer. And he who works with his hands and mind is a craftsman. So I strongly believe and have a faith that the surgery is here, and that's what flows into your hands, and you create a play, you call it surgical show. I find it important that if you look at this slide, the modifications and innovations of time, that time has journeyed us into countless years. And look at the man who was wandering for food and shelter. And in the picture next to that, you will find that he has just created his gadgets. You can look at the gadgets of surgical theater and the way he was operating. And you can see the gadgets of instruments that were available. And it is only with the modifications and the innovations that we went to this. You could see this, the red mark, the red line on the abdomen, trying to show you the open method of surgeries, where you could open the abdomen and perform a surgery with the hands. And next to that, you have a picture which talks about only holes. You could see those small holes all over the abdomen, and that's buttonhole, or we call it band-aid surgery or laparoscopic surgery. And next to that, it is only because of these innovations and modifications that keep on cropping up. It is the idea that matters, that is shaped into being into a technique or a method or a maneuver. And you see this gadget that's called a robot. And where is the surgeon now? You look at the surgeon is secluded with a machine called as a console, that is a robotic console. So from the wandering days of seeking food and shelter to present day, this is just what the time has brought us into. Ergonomics is your interaction with the instrument, patient, and yourself. So how you interact with yourself, how your instruments have to be handled, how the patient has to be placed, how the gadgets have to be put in the theater, is what ergonomics is all about. And we will talk about ergonomics with special reference to the port making in laparoscopic cholecystectomy or other procedures, and with a special reference to our innovations and our work we have done with reference to the point where exactly what you call as this epigastric port should be made. Now, it is just like, friends, when you enter into the car, the first thing you do is that you check the brake of the car, you check the lights, you check the dimmer, you check the wipers, and then only you start the car into action. Otherwise, if you do not do that, you might create blunder, you might create an accident. That exactly is what a surgeon has to do when he enters into theater. He has to check his gadgets. That what in totality means ergonomics. Well, I take you to laparoscopic cholecystectomy. Laparoscopic cholecystectomy is, we have seen a 4-port technique, we have seen 3-port technique, we have seen 2-port techniques, sills, notes, then robotics, and I don't know what next is going to come. Now, we had open surgery, we are into laparoscopic or robotic surgery. If we compare the two, an open surgeon versus a laparoscopic surgeon, how are they going to be different in the theater? An open surgeon, you will find that he does his job fast, while as a laparoscopic surgeon is very slow and steady. What's the reason? An open surgeon is fast because he has a three-dimensional view. Abdomen is opened. He has a tactile feedback with his hands. He's performing his surgery with the hands. So hands are as good as eyes. While as a laparoscopic surgeon does not see into the abdomen, does not perform surgery with his hands. What does he do? His eye is in the hands of his assistant. That is the cameraman. So he will stop. He can't perform the show when he does not see. That's when the endoscope is not in play. Here in open surgery, the dissection precedes hemostasis, whereas in laparoscopy, hemostasis precedes dissection. The reason is that in open surgery, if the bleeding is there, you dissect, and bleeding is there, you can control it there immediately, whereas it will take time. So it is better, there will be a readout, and which will mop up the light. So you first hemostasis, you do hemostasis first, and then you cut. So these things are important. That is the reason why in open surgery, ergonomics is optional, whereas ergonomics is very vital. Everything, your safety, your speed of the procedure, your comfortability, the fatigue goes off if you are ergonomically placed. If you are yourself, your machine and your patient, it is for the safety of all the three that you do a foolproof procedure. Now, to be an efficient surgeon is not only to, gulp up or mop up a lot of knowledge. Surgery is a craft, as I have been talking about, as you all understand and know. We concentrate on two important things. The one is the equipment, and then is the environment in the theater. The theater environment is very important. Your mood before you operate, it affects the team, whether it's cooperative team, whether they are really equally important, is important. Then the equipments is like the different gadgets that you are going to use. Are they really in work, or are they defunct? It's not that you are being given a seizure, it does not work. It will irritate your mood and it will reflect the total outcome of the surgery. So we go to the ergonomics. Now what are the general principles of ergonomics? And the ones which I am going to talk about, they comprise the major bulk and general principles of ergonomics that we need to apply. I will read them out for you. You have to understand that these are important points that you have to apply before you venture onto the journey of surgery on a patient. That is the straight line principle. You have the principle of triangulation. You have certain angles. We call them a manipulation angle. You have elevation angle. You have the table height. That is very important. You should not have a table height up. It is like just you sit for a computer. How do you sit? Your hands on the either side, and the computer, your hands, and if they are placed high up above the levels of your shoulders, is very difficult to perform the action. Exactly how should your patient be? The table should be low-lying table, and you have to put your instruments, your elbows have to be low-lying, your gaze has to be a little down. Okay, these are gaze down view. These are important principles in ergonomics in laparoscopic surgery. Now let's discuss them one by one and understand what does it mean to have a straight line principle. Now, what is a straight line principle? After you put the patient on the table and the surgeon comes whether on right or left side. See, for example, in this picture, what we are going to trying to tell you is what is straight line principle. So the surgeon, you see the pathology. If you suppose, for example, in this picture, I'm trying to show you, you're doing an appendectomy. So that is the pathology. And you see on the other side, you see the monitor. If you join the three, that is the monitor, the target organ you have to remove, that is the pathology, and the surgeon, they fall in a straight line. If you join these 3 points, they should be in a straight line. This is what we call as straight line principle in laparoscopic surgery. Second thing is visual axis and motor axis. Now it is very important. You will understand that when you perform an action where your vision and your motor action is in the same direction, you do better. Your efficiency is better. So the monitor that you are placed, you have to have around 7 to 10 feet distance between the surgeon and the monitor. And your vision, your visual axis. Now in this picture you can see the surgeon, you can see there is a simulator, take it for a patient, and then on the other side you find there is a monitor, he is watching the monitor, and his motor action, that is hands, are exactly in the same direction as he is looking. This we call visual axis and motor axis. Say for example, if the monitor is placed to the right or the left and you are performing an action, you will find you will jitter, you will create problems, your speed will go off. So that is very important point, that visual axis has to be married to your motor axis for a better outcome. Now there is a word like coaxial alignment. What is coaxial alignment? I am trying to show you by this picture that coaxial alignment and a lateral coaxial alignment. Coaxial alignment means the surgeon, the patient, that means your action, the motor action, and the monitor. And you can see in this view, the coaxial view, they are in the same line. So your efficiency increases in this view. You see the other view, the lateral view, your monitor is on the left side, your patient is on one side, and you are watching or performing action, watching on the other side. This is a wrong way of performing a surgery. This is where you can create problems. This is where you will take a lot of time. This is where you will get fatigue. This is where you will not enjoy the surgery. So kindly understand that when you perform the surgery, do it in a coaxial alignment, a coaxial mode as depicted in this picture. Now let us go back to a very important concept which I believe you must have been through. That is a baseball diamond concept and triangulation in laparoscopy. Now what is baseball diamond concept? I have tried to show it with a picture. If you could just look at this picture, that this picture will tell you what exactly is a baseball diamond concept. You see that the port, you can see the right hand port, the left hand port, they are the working ports. You can see the monitor is on the other side, and the surgeon and the cameraman is at the umbilicus. If you join them, they should make something like a field of the baseball. You see on the other side how the baseball field looks like. It corroborates to this picture on the patient. This is how your ports should be placed, and they should respect this principle of baseball diamond concept and triangulation. See, it makes a triangle, baseball triangle. Exactly, you see your first port, the camera port, has to be around 10 centimeters minimum away from the target organ to get a good focal length, and then your ports have to be distantly placed around 5 centimeters from the other port, and the right port, the left port. I must tell you that why it is important. You know yourself, if you look at the Creator, He has made us exactly in that triangulation way. I should tell you, this is because our eyes are in the center. You can see eyes are centrally placed, and our hands are placed on either side, the right hand, the left hand, and eyes. What are eyes? Eyes are the camera, and these are the working ports. This is exactly how God has created man. You follow, if you accept and believe and follow this principle, this is what is the concept of triangulation in laparoscopic surgery. Now, I should tell you something very interesting. Many people do not give value to this, but if you are very efficient, your results of surgery depend on giving importance to these points in ergonomics. We talk about certain angles in laparoscopic surgery. Now see, I just have given the names of these angles. You have a manipulation angle, you have an azimuth angle. These are very two important, and elevation angle. These are 2 or 3 important angles that you need to know. what is a manipulation angle? Now kindly understand that manipulation angle is exactly when you sit down for feeding from a plate with a fork or the knife. This is exactly you sit. Look at the plate where you have a fork and the plate. They make an angle. If you increase this angle, you find difficulty in eating. It is like the fork and the scissor. What is this angle going to make? You see, you are not conscious about this, but you automatically create an angle. This angle we call as the manipulation angle, and it should be around 60 to 70 degrees. Say that is an angle that when you enter into the abdomen, your two ports should make. This is the angle that is made between the two working ports, and it has to be around 60 degrees for the better performance of the action. Any surgery laparoscopic will be done. Now what is this other angle? Azimuth angle. Now azimuth angle is, if you draw a line, if you dissect this manipulation angle, it will be 50% of the manipulation angle. Azimuth angle is the line that you draw between the two ports and divide it into two. That is, if you see the camera is in between and two ports are on either side, you can say it is the angle between the camera port or the camera and one of the working ports. You see, that is what the angle it makes, and it has to be around half of the manipulation angle, that is 30 to 45 degree. As drawn in the picture, you can see. Now elevation angle is very important. Now what is elevation angle? Now look at this picture. This surgeon is struggling, his shoulders are high up. Now what should be the angle like? Angle should be around 60 degree to around 70 degree should be the elevation angle. Elevation angle is the angle that your port, that your working port will make with the surface of the abdomen. That is called elevation angle. Now this elevation angle is very important. If your table is high up, then you must have been seen that some of the laparoscopic surgeons use a wooden block. They stand on that wooden block. What is the idea? Idea is to create an angle of 60 degree of your working port with the surface of the abdomen. This angle has to be respected, because if you are comfortable, you are only comfortable if you give value to maintaining this angle of elevation angle. Your speed will improve, your fatigue will go off, you will enjoy this surgery. So that is elevation angle. Now what are these ideal angles which we need to respect? Look at this picture. We have seen a camera in the middle and two ports on either side. The angle between the ports is the manipulation angle. The angle between the camera and one of the working ports is the azimuth angle, that has to be 30 degree, manipulation angle 60 degree, and elevation angle is the angle that the port, that the instrument going through the port will make with the surface of the abdomen of the patient. That is should be around 60 degree. If you give value to these angles while you are performing this surgery, you will have, it will add to your speed, it will add to enjoying the procedure, it will add to your safety and your patient's safety. Now there is another important point which we have from physics, and that is the fulcrum effect of hand instruments. Now what is this fulcrum effect of hand instrument? I am trying to show it in the diagram. You see, when the port is placed, you see, you just put the instrument, your port is placed and the instrument goes through the port, and this instrument, most of the length of this instrument is between 32 to 36 centimeters. Now the important thing to say is that we have to make sure that we work with type 1 liver. Now physics divides livers into type 1, type 2 and type 3. Here we work with type 1 liver. Now what is type 1 liver? Type 1 liver is that your instrument length 1/3 should be seen or should go into the abdomen. The middle 1/3 of the length of the instrument should be in the trocar that you have made, and the rest 1/3 should be outside the abdomen. That is the only way to work with a type 1 liver in laparoscopic surgery. So in type 1, the fulcrum is in the middle, the tension is on one side and the load is on the other side. The load is the organ that you are removing, tension is the pores that with which you are operating, and the 1/3 that is in the trocar is the fulcrum. You will be very comfortable. If you go to type 2 liver or type 3, you will find very difficulty by performing this surgery. So whenever you are doing this, give credit to the port making and understand that you try to maintain this fulcrum effect in laparoscopic surgery for a better outcome. Now, is it possible to have an ideal port? It's a dream. Ideal things are always dream, but the search continues, and we are into this search of creating the ideal port. Let's hope one day we find what is ideal port looking like. But I should just tell you the ergonomics of port making. Just principles are that the target organ, say for example, you have to remove the gallbladder, or you have to remove the kidney, or you have to remove somebody's patient's appendix. Say the target organ, the first port, that's the optical port. Usually we make it in the umbilicus, that is called the weaving port. It has to be around 10 centimeters, 10 to 15 centimeters away from the target organ. Why it is important? This is important because you will have a better resolution, a better focal length of the organ available, and you can have a lateral vision also. The port that the operating ports are on one and other side, you can see these operating ports, one on each side. They should be around 5 to 7 centimeters from the optical port. And then if you need a rescue port, or what you call as a retracting port, or an accessory port, that should be placed another 5 centimeters away from this. Now if you see from the target organ, if you join these all ports, they make a line, a semicircular line. This is called the principle of arc. This principle of arc of port making has to be respected. The ports have to be designed in a situation that is like an arc facing to the target organ. That's what this diagram, this picture reflects to you. Friends, while we were into the work for these last more than 15 years into this laparoscopic cholecystectomy, we found that epigastrium is a word, given that when we say that you have to make an epigastric port, please understand that it struck to us that epigastrium, being the reviewer to many national, international journals and doing this editing job, we found that we went to the literature, we found that they call it to make an epigastric port. And when we understood what does epigastrium mean, epigastrium means a region. Now look at this diagram that we are showing you, that there are 4 quadrants and there are 9 quadrants in the other picture, and you all understand that epigastrium is a very big domain. It is like a country where exactly you are going to make this port. Now when we went to the literature, we saw that this subxiphoid area, they mentioned the epigastric port should be placed. Because why epigastric port we are concentrating? Because epigastric port is a very important port, because it is your right hand, and most of us are right-handed surgeons. If it is placed at the right place, job gets easier. So they mention it in the subxiphoid area. They mention make it between a line drawn from xiphisternum or umbilicus and xiphisternum 2/3, 1/3. To us it looked baffling. So that was the genesis of creating our port. What we said that we create, divide the abdomen, by 2 lines. You see the straight line that is drawn, one line that comes mid-sternal and it passes through the umbilicus. The other line is that we draw it by placing our left hand, index finger will go to the 9th costal cartilage and the thumb will rest on to this line, which is exactly mid-sternal line. In line with the umbilicus, we span our left hand, and this is the point, the intersection point, which we say that this is the point where the epigastric port should be made. This usually comes in the midline. Now, why do we say here? We have an evidence-based medicine. We have our experiences which we have published, and we have drawn it from that this is exactly the very importantly a specific point. Like we have McBurney's point, we have Palmer's point. This is where our port is placed, and this port is the exact site where this epigastric port should be placed. So this is the maneuver of placing the epigastric port. Now observations are, it's very easy to locate this port by doing our maneuver. It adds safety because the bleeding, if you go lateral to this, right or left, you might have vessels and you will injure the vessel, there will be bleeding. It adds speed to the procedure. It causes less portal bleeds. It needs less thrust. It usually falls to the right of the falciparum ligament, because you always try to come to the right of the falciparum. If you go through the falciparum ligament, then you will understand your problems of stones getting stuck up, some bleeding may occur into the falciparum ligament, and adds technical ease to the surgeon. It is very easy to be learned, taught and practiced by the young surgeons, and we usually talk about this point when we do laparoscopic cholecystectomy. And we published our results. This is Surgical Science. We published it in 2013 with a number of, very good number of surgeries we have performed over the last more than 15 years. And this is the genesis that we have come up with the port, a specific point where it should be placed. After 6 months only, we found another paper where people are interested in knowing the position of the epigastric port, and we found people really are understand the value of ergonomics in laparoscopic surgery. I thank you all, and I think we should keep on conquering, and I would say that ergonomics is the crux of the success of the surgery, in laparoscopic surgery especially, and give value to it, practice it the way we have described it, and then see the taste of performing surgery. Thank you very much.